And next, we will talk about the pathophysiology of the cerebral palsy. I will divide in a lesion of the white matter injury. For example, peripheral leukomalacia here. This is, you can see from the slide. This the picture of the transfer 41 that we can see from this problem of the area of the periventricular. We call the peripheral leukomalacia. This pathology is coming from the premature infants or preterm infants. This problem is around this area is the periventricular. I will show you how, because the PVL is the most type of cerebral palsy is the CP spastic diplegia. Because of this problem, you can see here, this is an area of the lesion in the middle of the subcortex here. This is, we call the periventriculum. This is in the ventricle, and it's a periventricular. And according to the distribution of the corticospinal tract here, the motor cortex here, this is the leg, and then this is from the trunk. So the leg from the trunk here is trajectory from the corticospinal. So the problem from the periventricular leukomalacia is become of the weakness of the leg and trunk. So that's why this pathology is make the problem of cerebral palsy spastic diplegia. So this is a common problem in the preterm infants because of this matter. The other white matter injury is called germinal matrix or germinal matrix intraventricular hemorrhage. This is also from the preterm infants because of the bleeding in the area germinal matrix here. And then make a hemorrhage in intraventricular. So we can see here in MRI, this is a bleeding in the intraventricular. So we call germinal matrix intraventricular hemorrhage. So this problem also same with the periventricular leukomalacia. The most common form of cerebral palsy is cerebral palsy spastic diplegia. The other pathophysiology of cerebral palsy is because of the GMI or gray matter injury. Gray matter injury, the problem is not in the subcortex, but in the cortex problem. We can see here the problem is not in the subcortex, but in the cortex area here. So for example, because of the intracerebral hemorrhage, this is the hemorrhage here. So depend on the lesion in the cortex here, the pathophysiology according the cortical spinal tracts here is the form is maybe becomes CP spastic diplegia, but in the more wide cortex is become cerebral spastic quadriplegia because the problem of the cortex. The other problem of the gray matter injury is the intracerebral infarction. You can see here like intracerebral cortex for the unilateral problem here, and then this is the bilateral infarction. And one of the case, the other case is the neonatal strokes. Is also make a form of cerebral palsy depend on the lesion. Sometimes become CP spastic diplegia, sometimes become a CP spastic quadriplegia. Some say from, for example, neonatal shock here, the form of the pathophysiology is become a CP spastic hemiplegia. The other gray matter injury, the common problem is from the maternal infection. For example, toxoplasma and rubella syndrome, cytomegalovirus, or herpes simplex virus. So again, depend on the width of the lesion in the cortex. Is in the form of cerebral palsy, the most of them is become a cerebral palsy spastic types. The last common, the pathophysiology of cerebral palsy is in the DGM or deep gray matter injury. So sometimes people say it as the basal ganglia injury. Yeah, for example, the most common case is because of the hyperbilirubinemia or icterus. The problem is not in the cortex, not in the subcortex, but the problem in the basal ganglia here. Sorry. The problem in the basal ganglia here. So because the lesion in the basal movement, the gray matter or in the basal ganglia, the form of cerebral palsy is dyskinetic. The some of cases is athetosis, like athetosis, and some cases like chorioathetosis, and the some of case the basal ganglia disorder is the dystonic problem. So next we will talk about the clinical classification of cerebral palsy. We can see here in the red color is the place of the lesion here in the one side of the cortex, therefore become the cerebral palsy spastic hemiplegia, and two sides in the superior cortex, left and the right sides, becomes to be spastic diplegia, and the wide lesion of the cortex, bilateral cortex, is quadriplegia. And the problem of the basal ganglia here is become athetosis and dystonic, and the lesion of the cerebellum make a from ataxic cerebral palsy. So I think this is the common classification of cerebral palsy. We call there are two types. The first is like a regional involvement or partial involvement of body parts, like hemiplegia in one side and CP spastic diplegia in the lower sides, and from the quadriplegia in the both side. But we need to understand here that global or total body involvement, like a cerebral palsy spastic quadriplegia and also the dyskinetic cerebral palsy, we call global or total body involvement. So this is the most severe problem is from the cerebral palsy spastic quadriplegia and the dystonic form. And the other tips also from the ataxia. So it's a clinical classification of cerebral palsy, but I want to encourage you not only to make a clinical classification, but also you need to make in functional classification. I will show you later for the functional classification, clear explanation about the type of clinical type of cerebral palsy. This is from the spastic hemiplegia. This is spastic diplegia. There is problem here. Asymmetric in the one side of body, and the spastic diplegia is the most problem in the lower body, and spastic quadriplegia is all body parts, and this is athetosis or dystonic problem, and the last type is the ataxic problem. I will show you the video here. you can see more clear about the classification of cerebral palsy. This is a spastic hemiplegia. You can see here the left side is normal and the right side is more weakness in the left side and make in the walking is more asymmetric. And this is the form of the hypotonia. You can see here all the muscle tone is decreasing. We call general hypotonia.
Now, this was examined and went this thing, supine position.
Yeah. And the other classification is spastic diplegia. We can see here the most of cerebral palsy spastic diplegia able to work. Some CP spastic diplegia able to work independently without any walkers, but some of them working with devices. Yeah. Here is spastic diplegia. The problem is in the lower extremity. Okay, next, this is a cerebral palsy atetosis. You can see here the child control the movement. Yes, some dyskinetic problems, some problem in the more the proximal body parts we call chorioatetosis, but some and the last video is the cerebral palsy ataxia problem. The most problem in the ataxic CP is the balance problem and also the coordination of extremity, like a hand function. So you can see here, difficult to stand, difficult to walk because the imbalance. The surveillance of cerebral palsy in Europe, this is making the 2000, make it easy for the classification of cerebral palsy with the algorithm here. First, the first question is there any persisting increased muscle tone or any spastic we can found in this child? And then if yes, if we found is in the left side, the spastic in the left side or in the right side or the both side. If the spastic in the both side, it must be spastic bilateral. Yeah. maybe cerebral palsy spastic diplegia or spastic quadriplegia. But if the spastic only in the left side or in the right side, it must be spastic unilateral or spastic hemiplegia. But if we didn't found any spastic or any increase in muscle tone, the other question is the tone varying, or if we found like a fluctuating tone? If we found fluctuating tone, it must be dyskinetic cerebral palsy. Yeah, if the other question is the involuntary movement more in the distal part or in the proximal part or in the more in the posture, so which we call dystonic cerebral palsy or chorea or atetosis. But if we didn't found any spastic or any fluctuating tone, the last question is if there any generalized hypotone, so maybe like a pure hypotone, or if we found imbalance problem, if we found like a more coordinated problem, it maybe become the ataxic cerebral palsy. So this algorithm make us easy to how to make a clinical classification of cerebral palsy in our clinical practice. But the second things we need to understand, we need to make the functional classification, not only clinical classification. So I will show you one of the most popular functional classification in cerebral palsy is gross motor function classification system. We can divide in the level 1 is a mild functional problem, and the level 5 is the most severe problem. We can see here. And then the other functional classification of cerebral palsy, not only GMFCS, but also we call MACS. MACS is a manual ability. We need to classify of the hand function. We call manual ability classification system. The other classification, communication function classification system. How children to speak and to interact with others. And the last functional classification is EDACS, or eating and drinking ability classification system. So the most important thing for the PT is the GMFCS. Next, from the primary problem in cerebral palsy, the first problem is abnormal muscle tone and posture. We can see here, this is the head lag. It's the most common problem in the first months of the infants. No head control or head lag, inactive trunk. Sometimes we can see like abnormal posture in the lower extremity, like a tiptoeing or plantar flexion position. And some of the infants show the toe curling. It's shown the hypertone in the lower extremity. And in the arms, we can see like an arm rotation, or this is the hand thrusting, persistent hand thrusting. And sometimes we can notice the scissoring in the legs, and also like a total pattern, like extended spasm here. This is the primary problem in cerebral palsy we can see from the infants. This is a common abnormal posture of hypotone. We call this position a frog position because they're all out of the midline. And this is a hypertone. We form the extended spasm. And then this is the fluctuating tone, the form of the dyskinetic problem. The associated problem of cerebral palsy, like a visual impairment, yeah, some children, it's difficult to in the visual function, auditory impairment, a joint contracture in a musculoskeletal problem like a joint contracture, hip dislocation, and also the postural problem like a scoliosis. and then seizures, malnutrition, and the most dangerous complication or associated problem in cerebral palsy is pneumonia. Yeah, it is like the severe respiratory problem. And the last section I want to share with you is about the update of early diagnosis of cerebral palsy from the AECPDM recommendation 2017. This is now about the two major pathways to accurate and the early detection of the cerebral palsy. The firstly is according to Professor Ian Navak study from Australia. Yes, I have attended some webinar with him, with her. Uh, this is some study of the early diagnosis of cerebral palsy. The most remarkable is that now the diagnosis of cerebral palsy is accurate diagnosis in under 5 months. So under 5 months, early diagnosis begin like a medical history, neuroimaging, and using standardized neurological and motor assessment. So I think good news for us that we able to early diagnosis of cerebral palsy. And here is the two algorithm of the early diagnosis of cerebral palsy. In the left side, we can see here is like for under 5 months of age, and the right side is more than 5 months of age. The risk factor of under 5 months, we call newborn detectable risk, as I mentioned in the previous slides. They're like a preterm encephalopathy, and we need to conduct the neurological examination. Of the neurological examination is Hammersmith infant neurological examination here. Hammersmith infant neurological for the neurological examination, and then for the motor functional assessment, the most popular and the most recommendation is general movement assessment. I saw in the schedule this Professor Hirotaka from TMU will give you a lecture about the general movement assessment. And the other motor function assessment here is like a TEMP or TIMS, test informative performance, or like a Alberta Informative Scale for the motor function assessment. And of course, we need neurological imaging like a MRI. So there are three important things need to do for the early diagnosis. Yeah. Neurological examination, motor function assessment, and then MRI. So here we can see under 5 months for the MRI, general movement assessment, and also for the neurological examination here. And then for the over the 5 months, because of the GMA only conducted in under 5 months, we need to change from the motor assessment using AIMS or some with the teams to make a motor assessment of the infants. And the next slides, after we combine assessment, finally we can be able to make a classification. First, high risk of cerebral palsy, or definitely CP, or definitely not CP here. And next, we need to determine the severity of cerebral palsy with the clinical or the functional classification of cerebral palsy. And then we can make a prognosis, like a likely ambulance or likely non-ambulance from the HIMSS score or from the MRI. Here, we can see here MRI white matter injury And then here, what MRI with gray matter injury, we can see here in the white matter injury or in the subcortex, it's more likely ambulance compared than MRI in the gray matter injury. It means the lesion in the cortex, it's more severe than in the subcortex. And also from the Heinz score, is if the more than 40, it's more likely ambulance compared is the lower than 40. And then we need to determine preliminary topography like a spastic diplegia or spastic quadriplegia or hemiplegia, unilateral or bilateral spastic. And then we need to assess associate impairments. Yeah, and then the last, we need to arrange early intervention program. So this is a good new for us about the algorithm of early diagnosis of cerebral palsy. And the last part, I will talk about the PT intervention for the high-risk cerebral palsy. We need to start intervention of cerebral palsy, not wait and see after 2 years or after 3 years, but we need to start the early intervention as soon as possible. Start from the NICU room. I think Professor Susan Campbell, I think the most popular professor pediatric from United States, they make a systematic review for the evidence for effective intervention from the NICU. Here you can see here a lot of intervention from the, for example, NDT for the very low birth weight in the NICU. Also, it's like a sensory motor stimulation, like it's the auditory, tactile, vestibular stimulation, something like a joint compression, passive movement hydrotherapy. This is start from early interventions, start by professional in the NICU. And the other things, we have a new study for the early intervention guideline of cerebral palsy regarding the Novak and the Morgan. We call like a green light or yellow light or red light, like a traffic light, like a traffic light for the guiding us to give the intervention model to treating cerebral palsy. You can see here that maybe it's a too small letter, but I will explain some important information here. The green color here is the most effective intervention. Yeah, like a CIMT, like a bimanual intervention, home for the walking is like a partial body weight super treatment training, some strength training, or treatment training, task specific training. For the tone, like a BONT, and then selective decision. And then for the yellow part, it's the two sides. This is beyond the word line, and then under the word line is the possibly effective. You can see here a lot of intervention, possibly effective. But if the under word line here is possibly not effective, but in the red line, in the red color is the not effective intervention. And for conclusion, I will share some case reports from my practical experience. Here the case one from the high-risk cerebral palsy. And these infants start to get early diagnosis in 1 month of age with high recipe, and then start intervention in 1 month. Sorry. And then start from the visual training, increase the neck control, and then start to sitting posture exercise. And then finally, now he able to walk independently. He can jump in around his house. Yeah, I think this is very good outcome because of the early diagnosis and early intervention start from the first month. The case number 2 is cerebral palsy spastic diplegia here. This is the first coming in our clinics with the seizure. This is like a typical of the diplegia. It's like a seizuring with the plantar flexion because the tiptoeing and the bunny jump. Yeah. And we start the intervention because the most problem in the lower extremity, she difficult to support with her feet. So we try to train to support the body on her feet. And then after the therapy session, we can see here, she start able to walk using walker. But PT not only train from the impairment and activity level, but also in the participation level. So that's we start to in the classroom with the OT, and now she enter in the special school. The case number 3 is cerebral palsy spastic hemiplegia. Here we can see here is the problem in the more in the left right side. We train in the both side bimanual training from the right side and the left side to make the more asymmetric posture, and train to in the activity level like standing and walking exercise in the more symmetric posture. And then in the participation level, we collaborate with the special teacher to make in the sitting and the standing and the walking posture in the more bimanual training in the more symmetric posture. Case number 4 is cerebral palsy spastic quadriplegia. Yeah, I found this child in the community services with the problem hypertone in the neck and the trunk and the subluxation in the hip. And finally, we start to we start to train with also with family intervention. We see here is very good alignment, no contracture, no hip dislocation, no postural problem. And then we try to make in the more activity level in the standing using
Yep.
the hip trainer.
Not
And
just the body kit. Yeah.
this
Okay.
is his mother doing some playful activity with the parents at home to maintain the head posture, hand function, and also for the good posture at home. Case number 5 is the CPT kinetic. We can see here the problem is like difficult to control the movement more in the right hand and the left here. Because she very like to drawing, and we try to make hand function to drawing activity. And finally, now she is a painter with a special children with a painter. Sometimes it's like a show. The picture in some communities exhibition. The last case is CP ataxia. So this problem because the injury of the occipital lobes, because the bleeding of the occipital lobes of head trauma, and then the problem in the most in the cerebellum lobes, And then we start the intervention to build a postural tone, make the good base of support, and then make a balance. We combine with horse therapy on the riding therapy or the hypotherapy. And then finally, now he able to ride the ATV, and then he can able to participate in the school. So I suggest you the PT intervention not only to solve the impairment level, not only also in the activity level, but we need to train the children cerebral palsy in the participation level. So that's all my presentation about the basic understanding of cerebral palsy. So I think that's all. Thank you very much for listening and time. Back to moderator. Thank you.
Okay. Thank you for Dr. Johannes for your insightful presentation on understanding the basic of cerebral palsy in children or giving the introduction about cerebral palsy. Your detailed explanation provided clarity about the pathophysiology of cerebral palsy, and it is a group of permanent disorders affecting movement, posture, cognition, and communication. The importance of early diagnosis was emphasized, along with the role it plays on improving the overall management and development of children at high risk. We appreciate your expertise and the valuable insights shared today. Now we will move to the Q&A session. We will have 15-minute Q&A session. Feel free to type your question in the chat box, or you can use the raise hand feature and we will address them one by one. Okay, is there anyone who want to ask? You also can send your question in Bahasa Indonesia and we will help you to translate it into English. Okay, for Anggun Indah Lestari, you can ask a question directly.
All right. Thank you, moderator, for the opportunity. Can you hear my voice right now?
Yes, yes, you can.
All right. Okay. I think it is kind of interesting presentation that Dr. Mr. Joe that given to us today. So I kindly interesting that it is mentioned in the pathophysiology section. All right. There is injury uh, to some microscopic materials in the brain in cerebral palsy condition based on MRI examinations. So my questions is how actually we could identify the primary problem if there is a case we found from radiology examination stated that lesion in the brain or the damage in the brain cannot found, but based on electrical activity examinations such as EEG or electroencephalogram, they're found epilepsy waves. So, but based on the patient's history, there is no seizure before. How could we identify in a complex case such as that? Maybe it's my question,
Yeah.
moderator.
Oh,
Yeah.
sorry. I directly answer or just waiting the other questions?
You can answer it now.
Oh, okay. This is a really good question. And the problem is not for the professional, also for the parents, because the the the, the three major of the early diagnosis is the first from the clinical examination. There are two parts. It's like a neurological examination and the motor examination, and the additional is for from the MRI, from the radiological finding. But you mentioned about the EAG. Is if the MRI is normal, but EAG is like a epileptic form, but in the clinical is no found any epileptic form. So how we can design, this is a cerebral palsy or hairy cerebral palsy or definitely not CP, something like that. But the most important thing is the clinical examination, the clinical sign is the most important thing. For example, if we found the clinical examination from like a neurological finding, we found like a head lag, inactive
Recording
trunk, or
stopped.
sometimes it's like for persistent hand fasting or just scrolling or something like extended spasm. If we found any neurological clinical sign of our neurological examination, uh, but in the radiological finding, yeah, from the MRI or the EAG, is
Recording in
no
progress.
any finding. So we keep still in high risk cerebral palsy. But if we found any positive sign from the MRI or from the EAG, said like EAG is like additional more from the examination. But if we couldn't found any clinical sign of the cerebral palsy from the neurological examination and also from the motor problem, so we cannot define as the cerebral palsy. So the MRI, EAG, and the other additional examination is just for the additional. The first important thing is not for the clinical finding, from the neurological examination and the motor examination. This problem actually published in one paper. Is very good paper. Maybe I will share with you. For the committee, I will send the paper about this problem. It's from the neurological finding and the clinical findings, so like algorithm of the how to decide a cerebral palsy or high risk cerebral palsy or not cerebral palsy. So I think this my answer. Thank you.
Okay, thank you for the answer. Is there anyone who wanna ask question? Okay, while we waiting for the other questions, maybe I wanna ask something. What is the ethical concerns arise when using artificial intelligence-based assessment for diagnosing cerebral palsy in newborns? Maybe that's is the question, Dr. Johannes.
Yeah. Thank you for the good question about the artificial intelligence, because actually my study here in Taiwan is focused on how to use artificial intelligence to early diagnosis of motor problem. Here in Taiwan, for the any technology used in the early diagnosis is like a clear regulation from the government in Taiwan, that any government is like encouraged to using any kind of technology to help a community to make early possible to make early diagnosis for any health condition. But the significant, remarkable, like a warning that any kind of technology is cannot replace any decision making from the profession, health profession from the hospital. So the using of the technology, for example, like artificial intelligence, is to use to early screening, not early diagnosis. So it's like we can differentiate very clearly from the screening using from the screening and using from the diagnosis. We encourage how to widely use all kind of technology to screening to make early detection, but from the clinical decision, from the medical diagnosis is have to this is like a clear regulation from the government in Taiwan. So I don't know how in Indonesia, but because Indonesia is still about the tele-rehabilitation. But I think it's the good way in Taiwan that the using technology is only from the screening, but now replace the medical diagnosis by medical professional at the hospital. And so I think that's my answer.
Okay, thank you to Professor Johannes for your answer. I understand about the ethical consideration for clinical screening for the diagnosis of cerebral palsy. It's not diagnosis, but it is for the clinic
Yeah,
for screening.
for the screening.
Thank you.
Yeah, actually, my study is about using artificial intelligence to early diagnosis and motor problem in infants. The first part is how to make a model from the preterm infants, and I start the new in the second study how to integrate the AI in the cell phones. So that's what make a parents can use the uh, mobile phone to record the movement of the infant at home and then send to the mobile phones and then get the result. This is the, oh, maybe your infant is delayed, so you need go to the hospital to get a medical diagnosis. So that's like the way how to use AI in Taiwan.
Thank you for the answer. Maybe one or two more question. You can send it in the chat box or ask directly.
While we waiting for the other questions, I found this study from the first question about your question. This is a infant high cerebral palsy. No, yes, from the clinical examination, and then from the infant has abnormal neural imaging. No, yes, and finally we decide this is CP or not CP. So I think this paper and this study is very clear how to answer upon the finding, any clinical finding or the radiological finding.
Okay, thank you. And questions from Valentina. Do you wanna ask directly your question?
Yes.
Okay.
Okay. Thank you so much for the opportunity. So I want to ask about the traffic intervention that you mentioned earlier. Do you use the effective intervention in your rehabilitation program from the case example that you present? Thank you.
Yes, thank you. From the NICU, I start the intervention in the NICU. I start using for the early positioning, all according the evidence base in big like positioning, like active stimulation. For example, like to use hand function, hand to mouth, hand to hand, and then hand to feet, stimulation, a kicking, activate kicking movement, and then a mix of positioning in the more flexion posture, and to make in the rolling and the sitting, like early stimulation and EQ. And then for the early intervention in the clinical intervention in outpatient, we actually in the traffic lights of the Novak et al. For the building the muscle tone, pediatric pop-up is not recommended. But we need to clearly understand that entity in the mention in this paper is for the original passive form. It's mean now entity or pop-up pediatric is developed more in the active movement, active visualization, more because the dynamic system theory changed all the intervention. So I use more in the more task specific intervention, like a hand function, like how you to use the visual training or the auditory training, something like that to develop in the more a higher level of activity. For the children who has very severe functional of the gross motor, for example, GMFCS level 4 or 5, I try to make it in the more level activity using like a mobility assisted, like a walker, like a kid trainer, to make the tutor able to move in a more higher level activity. I think Mr. Hansu will give more idea how to keep intervention according his clinical experience. But in my experience, I use a more goal-directed and more type-specific training to use in our patients. So that's all my answer. Thank you.
Okay, thank you for the answer. Now maybe one more question before we go to the next session. We will still have 3 minutes for the Q&A session until 12:10, 11:10. Okay, for Mr. Nohansa, please.
Hello, and Bobas instructors. You have a good question. Thank you so much. Just I want to tell you only one thing about the Novak's paper. Yes, of course, I saw and then I understand her paper, but keep in your mind, Novak's paper was written in the 1970s based on Bobas therapy. That was 50 years ago. The theory and treatment have significantly advanced since then. Okay, I will tell you later in my lecture. Thank you so much.
Yes, thank you, Hansu. I also in my lectures sometimes I give more understanding clearly about the novel paper about the traffic because the entity is not recommended, but in the novel clearly write in the original passive form. It's meant like in the traditional bobat, like
Yes.
classical bobats. So we need to update our
Yeah.
understanding how to bobat is like make evolution more in the task specific training, more in the functional training. So that's I need you to give the more explanation how the bobat evolution not
Yes.
only in the passive form, not only in the traditional way, not only in the classical techniques, but more in the functional training. So that I think
Yes.
this is the more important stuff that you need to share with us today.
Yes, it's okay.
Okay, thank you for all the questions. Now, before we finish the session, we would like to present a certificate to Dr. Yohanes Purwanto for his contribution today. Dr. Yohanes Purwanto certificate will be presented by Physio Nur Hikmawati Hasbiah as a mentor of Human Physio at the Faculty of Nursing, Hasanuddin University.
Thank you, Physio Dia. Good morning, Physio Yohanes. Excuse me, you are mute. Nice to meet you
Selamat siang,
again.
Mbak Hikmah.
Sehat, Pak. Oke, mohon diterima Physio Dr. Yohanes
Terima kasih. Sehat.
sertifikat dari panitia. Thank you very much for your presentation. Actually, also my boss in PT Children Association in Indonesia. Thank you,
Yeah,
Mr.
thank you
Yohanes.
very much for your effort for the student committees. It's very kind communicate with me. And I also apologize if any limitation in my presentation, but the webinar until the finish because I have to go to the lab today. Yeah.
Thank you. Okay, thank you, Physio Dia.
Terima kasih.
Thank you for Physio Nur Hikmawati Hasbiah. Thank you also for Dr. Yohanes for sharing your valuable knowledge today. Okay, next we will go to the next sessions. It is the second presentation. Before we begin the presentation, I will read the second speaker CV. Okay, our second is Associate Professor Hirota Kagima, a lecturer at Department of Physical Therapy, Faculty of Health Science at Tokyo Metropolitan University. Gima Sensei is also my supervisor in Graduate School of Human Health Science. He has been Associate Professor there since October 2021, following his previous role as an Assistant Professor in the same department from 2020 to 2021. Prior to that, he held the position of Project Senior Lecturer at the Child Development and Learning Research Center at the Tottori University from 2017 to 2020. He also worked as a project assistant professor at the Graduate School of Education, the University of Tokyo in 2016, and as a project researcher from 2013 to 2016. He completed his PhD in 2012 from the Interdisciplinary Graduate School of Science and Technology of Shinshu University and has been practicing as a physiotherapist for 22 years since 2002. He also has published numerous studies, including recent work on early infancy motor development, such as his 2024 publication in PLOS ONE, correlation between post-estimation features regarding movements toward midline in early infancy, and also relationship between fidgety movement and frequency of movement toward midline, and infants' behavior checklist for low birth weight infants and later development outcome. And there are also other publications, as you can see in here. His research continues to provide valuable insight into child neurodevelopment, and we are honored to have him here with us today. Now, he will talk about the relationship between characteristics of spontaneous movements in early infancy and later developments of cerebral palsy and neurodevelopmental disorders. Okay, please welcome Associate Professor Hirota Kagima. The stage is yours.
Thank you for introducing Dea-san. Can I hear you? Okay.
Yes, we can hear your voice.
Hi, hello everyone. I'm Hirota Kagima of Tokyo Metropolitan University. This time, thank you very much for giving me this valuable opportunity to make a presentation. So let's start to my presentation. I'll share my screen. Can I show my screen? Okay.
Yes, we can see your screen.
Mm-mm. Okay. Okay. Let's. My research interest is in the role of spontaneous movements and sensory motor experience starting from the fetal period in human development. Especially, I am interested in the interaction between the brain, body, and environment, and would like to obtain new knowledge that is useful for pediatric physiotherapy. Today, I would like to talk about the relationship between the characteristics of spontaneous movement in early infancy and later development of cerebral palsy and neurodevelopmental disorders. I'm not very good at English, so please forgive me if there are many pronunciations that are difficult to hear. The slide shows extremely robust weight infant with gestational age of 25 weeks and weight of 925 grams. As we know, developments in medical technology have improved the survival rates of preterm and low birth weight infants. Nevertheless, such infants continue to show increased risks of developmental abnormalities. Previous studies have reported long-term neurodevelopmental morbidity, especially cerebral palsy, cognitive delay, and neurodevelopmental impairment in very low birth weight infants. In recent years, there have been studies reporting the relationship between low birth weight infant and later diagnosis of ASD, autism spectrum disorder, which is notable. Okay. And the main hypothesis of my research is that the paucity of spontaneous movements and concomitant lack of sensory motor experience in low birth weight infants may lead to later developmental abnormalities. Human fetus and infants generate a variety of spontaneous movements and behaviors in early infancy. These have attracted researchers' attention and have been examined over recent years because sensory motor experience based on spontaneous movements and behavior is considered important for early perceptual and motor development. This figure shows the results of a study in which spontaneous fetal movements were observed by 2D ultrasound. The vertical axis indicates the type of movement, and the horizontal axis indicates the number of weeks of fetal age. The number of dots in the graph indicates the number of the fetus that shows the movement. As can be seen in the graph, the human fetus shows just this movement around 8 weeks of gestational age, followed by startle, general movements, and hiccup, and isolate arm movement or isolate leg movement. As shown of this figure, humans have generated various types of spontaneous activity and movements since the early fetal period. By 20 weeks of gestation, there are many types of spontaneous movements. One of the most interesting spontaneous movements is general movements, also known as GMS. And GMS are the most frequent and most complex pattern of whole body movements in spontaneous movements. GMS occur in the fetuses at 8 to 10 weeks of gestational age and continue to be present until 5 months of life. The right side of the slide shows a fetus at 14 weeks gestation. GMS are complex movements that actively move the whole body as shown by this fetus. It is thought that humans acquire sensory motor experience necessary for motor and cognitive development from the early fetal period by spontaneous movements such as GMS. This slide shows the developmental course of GMS. From birth until the end of the second month of life, GMS have a rising quality characterized by small to moderate amplitude and speed. Thereafter, GMS occur as so-called fidgety movements, which are characterized as small continual movements of moderate speed and variable acceleration of the neck, trunk, and limbs in all directions. There are numerous studies on the relationship between the GMS quality and neurological deficit. In particular, previous studies have shown that evaluation of fidgety movements by the observation assessment predicts later neurological impairments. This figure is the result of a longitudinal study on 130 infants reported in 1997 by Dr. Prestel, who defined GMS. This study showed that most infants with absence of fidgety movements later developed cerebral palsy, and those who showed abnormality fidgety movements later developed mental and motor retardation. On the basis of this report, research on the relationship between the qualitative characteristics of fidgety movements and later neurological development has attracted attention, and many studies have been performed. Okay. I think this paper was introduced in Dr. Johannes Proant's lecture earlier. In a systematic review summarizing the clinical reported of neurodevelopmental assessment method reported by Dr. Novak in 2017. The GMS assessment showed that the best predictive properties before 5 months of collected age. Furthermore, in the latest study report in 2019, GMS assessment showed the best predictive properties before 3 months of corrected age. The GMS assessment has been increasingly used to predict neurodevelopmental abnormality in clinical practice and research. Due to reports such as these on early diagnosis algorithm for cerebral palsy, the timing of early diagnosis has been getting earlier in recent years. This paper reports on the difference in the timing of diagnosis before and after 2018, when the algorithm for early diagnosis of cerebral palsy was released. The data is from a hospital in Wisconsin, USA. The graph on the left shows the change in assessment methods used for early diagnosis of cerebral palsy before and after 2018. It can be seen that the use of the GMS assessment has increased drastically since 2018. In addition, the right graph A shows that the time when cerebral palsy was first suspected has significantly decreasing since 2018. In addition, this paper reports that the timing of starting outpatient therapy for children with cerebral palsy has been brought forward from around 8.9 months before 2018 to 4.4 months after 2018. So we can understand that the timing of early diagnosis and early intervention for cerebral palsy is being brought forward worldwide. So far, I have been talking about GMS assessment and early diagnosis of cerebral palsy. But I will also be talking about other developmental problems. In this systematic review, the relationship between GM assessment and developmental delay other than cerebral palsy is reported. As we can see from the blue and yellow lines, the qualitative abnormality of vegetative movements in early infancy suggests later motor delay and cognitive delays. Our data on low birth weight infants has also provided some interesting findings. In this study, we examined the motor development of 43 typically developing children who had no diagnosis of cerebral palsy or developmental disorder at the age of 6, including 31 children who had no qualitative abnormality in their fidgety movements in early infancy, and 12 children who did have such abnormalities. The result shows that the postural and motor development score at the age of 3 years was significantly lower in children who had qualitative abnormalities in their fidgety movements. In addition, to diagnosis of developmental disorders and developmental delays, there have also been recent reports of associated to sensory processing characteristics. The paper on the left one reports that immaturity of sensory processing related to motor and tactile sensations. And right one on reports that immaturity of sensory processing related to visual and vestibular were associated to qualitative abnormalities in GMS in early infancy. Furthermore, in the paper shown on this slide, it was reported that fidgety movements were not shown in early infancy in many infants who later developed ASD, autism spectrum disorders. In this review paper, authors identifying association between motor abnormality in the first 5 months of infancy and later diagnosis of ASD or Rett syndrome. Authors indicated that the rate of occurrence of abnormal fidgety movements is exceedingly high in infants later diagnosis with ASD, and they suggested that to evaluate the abnormality of GMS fidgety movements as one potential marker for early maldevelopment. Okay, so far I have explained the relationship between GMA and GM assessment and later neurodevelopmental outcome. Next, I would like to explain the motor characteristics of general movements concurrently. The slide shows an infant with typical fidgety movements. As mentioned earlier, fidgety movements are characterized as small continual movements of moderate speed and variable acceleration of the neck, trunk, and limbs in all directions. These are all fidgety movements. Can you capture fidgety movements by visual observation? It is very hard. On the other hand, this slide shows abnormality fidgety movements. The left side shows abnormal fidgety movements, and the right side shows absence of fidgety movements. Can you see the difference from the normal fidgety movements? According to the definition of general movements assessment, abnormality fidgety movements look like normal fidgety movements, but their amplitude, speed, and jerkiness are moderately or greatly exaggerated. Furthermore, absence of fidgety movement is no fidgety movements can be observed, although other movements can occur, such as kicking or swiping. you may feel that you can distinguish these motor features while listening to my explanations. However, it is very difficult to observe and judge accurately in clinical practice. So based on the background described so far, I have been working on
Siapa yang dua?
okay. Okay. I have been working on study to quantify the kinematic features of fidgety movements. We measured the spontaneous movement of the infant in the early infancy using a video camera and 3D motion capture system, extracted the coordinate data of limbs movement and made it into a trajectory. Then we examined various indices calculated from this time series coordinate data and examined the relationship to the motor characteristics of fidgety movements. For the indices, we considered average velocity, number of motor units, kurtosis or acceleration, jerk index, lateral mobility index, correlation between limbs velocities, and average curvature. Among the indices we examined, the average curvature was the index that reflected the characteristics of fidgety movements the most. Average curvature is a quantitative index of the geometrical feature of the limbs movement trajectory. In our pilot study of 18 infants, the occurrence rate of fidgety movements during 10 minutes of observation and the value of the average curvature calculated from the limbs movement trajectory measured by the 3D motion capture system, they were significantly correlated. A larger study on the relationship between fidgety movements and curvature characteristics of limbs movement was performed in the paper shown on this slide. The study involved 163 infants and 3 specialists for GM assessment. The purpose of this study was to develop a method to level which movement features are associated with each rater's evaluation of fidgety movements based on the GM assessment. The results show that only the average curvature differed significantly among the ratings of the fidgety movement for all 3 raters. The value of curvature in this study was defined as the amount by which a trajectory deviates from being straight and is expressed at the reciprocal of the radius of the curvature. Therefore, high values of average curvature are consistent with the characteristics of fidgety movements, such as an ongoing stream of small and circular movement of limbs. That is defined.
Ada template-nya yang sekarang cepat bentar. Akan diarahkan.
The following slides shows a study on the relationship between the characteristics of fidgety movements and neurological development in very low birth weight infants. I'm sorry, that is in Japanese. paper. Please note the classification of fidgety movement at 3 months of corrected age and the neurological development at 6 years of age. Of the 44 very low birth weight infants classified as normal fidgety movements at 3 months of corrected age, and 32 had, corrected 44, and 31 had typical development, 8 had atypical development, and 5 had ASD and no cerebral palsy. On the other hand, of the 32 infants classified as absence of fidgety movements, 9 had typical development, 10 had atypical development, 8 had ASD, and 5 had cerebral palsy. Furthermore, the later development of an infant classified as abnormal fidgety movements was ASD. Our data also showed that abnormalities of fidgety movements are related with neurological impairments. In this study, only the value of average curvature also showed a significant difference between the group with normal and the absence of fidgety movements. These results suggest that higher average curvature of the limbs represents the presence of fidgety movements. Furthermore, our study may guide efforts in quantification of characteristics of fidgety movements and detection earlier signs of developmental disability. Especially about the cerebral palsy. Okay. There are other interesting findings. This study examines the relationship between the qualitative characteristics of fidgety movements and the frequency of MTM, movement toward midline. MTM is a movement of the limbs toward the midline and is considered important in motor development. This study specifically examines the frequency of MTM, such as foot-to-foot contact or foot-to-leg contact, hand-to-hand contact, hand-to-face contact, etc. So left figure shows the frequency of MTM in 32 cases where the quality of fidgety movements was normal. And it can be seen that MTM appear in most cases. But on the other hand, here are the result of 15 cases with abnormal fidgety movement quality in the right figure. You can see that MTMs did not appear in most cases. These cases often later developed cerebral palsy, suggesting that in addition to evaluating the quality of fidgety movement, it is also important to evaluate the frequency of MTM in developmental assessment. Let's move another one. This slide shows our studies examining the relationship between characteristics of spontaneous movements in early infancy and later ASD in very low birth weight infants. In this study, we examined the characteristics of spontaneous movements at early infancy in 39 children who had no clinical issues, 21 children who showed developmental delay, and 14 children who are diagnosed with ASD at 6 years of age. As a result, none of the indices or characteristics of limbs spontaneous movements we examined were related to later ASD. Therefore, we focused on other spontaneous motor characteristics. We analyzed the spontaneous movement of the neck, and we calculated the values of percentage of midline head position and number of change in head position. The results showed the values of percentage of midline head position were significantly lower in the ASD group than in the typical developmental group. We considered that the lower percentage of midline head position during early infancy is associated with later development of ASD, and poor performance in maintaining the midline position of the head at this period may distinguish infants who later develop ASD from those who show typical development. In addition, this slide also shows our study. In this study, we introduced the infant behavior checklist, IBC, and examined the relationship between the behavioral characteristics of low birth weight infants and neurodevelopmental outcomes at 6 years of age. The behavioral characteristics during the neonatal period and early infancy period were assessed in very low birth weight infants. The neonatal period on the left correspond to the phase when rising movements appear in terms of GMS, while the early infancy period on the right corresponds to the phase when fidgety movements appear. We assess the appearance of individual behavioral characteristics at each period according to the neurodevelopmental outcome. Of the 143 infants assessed during the neonatal period, and 89 had typical development, 30 had intellectual disability, and 24 had ASD. In 78 infants assessed during early infancy, 40, 21, and 70 had typical development and intellectual disability and ASD respectively. These are a list of IBC, infant behavior checklist. The IBC includes 44 common behaviors. In this study, we have developed a list of observation items based on methods from the neurological assessment, the preterm and full-term newborn infants, the newborn individual, and the newborn individualized developmental care and assessment program, which are commonly used to clinical practice to evaluate the behavior of infants. In addition, the other items were picked up for posture and behavior that the authors feel were commonly observed in clinical practice. The item indicated by the red squares are those originally proposed. Okay. Sorry. And the items were divided into two main categories, items related to posture and items related to behavior. That is results. This figure shows the distribution of the data for each item in the intellectual disability and ASD groups at neonatal assessment group and early infancy assessment group comes by the difference of percentage of participants for whom the posture and can you hear me? Okay. 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 Each line represents the value of the typical developmental group minus the value of the ID group and the ASD group with larger positive value indicating higher proportion of appearance compared to the TD group, and larger negative values indicated lower proportion of appearance each items. As you can see in the neonatal assessment group, the ID group exhibited significantly fewer instances of trunk rotation or separate finger flexion and extension, and lower limbs flexion and hip internal rotation or something. In contrast, there were no items in the ASD group that showed a significant difference. That is interest result. Okay. Okay. Next, I will move on the topic about physiotherapy for low birth weight infants. The figure on this slide shows the flow of physiotherapy given to low birth weight infants in the NICU NICU. There are three main objectives of the intervention. First one, respiratory and circulatory stability. Second one, protection from stress. And I think this third one is very important, which is to support their development.
Servis apa? Kita keluar, servis masuk. Enggak lah, pokoknya pakai.
Thank you. Okay, there are some intervention programs, and I think this therapeutic exercise is most important in supporting their development. The therapeutic exercise for low birth weight infants is practiced by physiotherapists in NICU all over the world. However, some negative data have been reported in recent years.